Okay, so good afternoon. Welcome all of you for this instruction course, which is measuring and monitoring way to improving quality of cataract surgery. So as we all know, so anything you want to improve, you have to measure. Without measuring, you will not be able to improve it. You will not know whether there is an improvement or a deterioration. So in that way, it becomes very important. Can I have the first slide? Okay. So I mean, any organization has only one challenge in building their practice. Now, everybody who starts a practice, they all have one challenge. What is it they want to have? Anyone who's starting a practice, what is it they are interested? There's only one thing you want to say. What is it? Number of cataract surgeries. More patients. So it's basically about how do you grow the volume of the patients. It's always important. So, because the reason being, every year your cost is going to increase, your expenses is going to increase. You cannot compensate that by charging the patients. No, if the patient volume is the same, you cannot just increase the charges by 10% or 15%. Every year you cannot do it. Only by volume you will be able to negate that. But even that growing has to happen in a very sustainable way. It should not be in an unsustainable way. So what is sustainable way is also about creating access, making the care affordable to the patient, and also you have to ensure quality. The quality becomes very, very important. I just want to share this one particular study done by an insurance company in America. And they asked their insurance, the people who have all paid the insurance, taken insurance, they send them a survey asking them, so if you want to choose a provider for your healthcare, whom do you consult? And you may consult many people, but you can give any number of people, but you can say whether they are very believable, somewhat believable, not believable, or not at all believable. That's how you also have to categorize them. So this is the answer they got. So 50% of them said they'll consult their family and friends. 29% said that they'll consult the second bar is all about the doctors. The 19% is about their organization. The next 19% is the insurance companies. And if you see in the end, it's the newspapers, TV, and others. So people may not really believe that. Then they also asked whether if the information given, will you believe that? The people who said no, they'll ask the family and friends. They said 70% of them said, we'll just take their word, we'll not take another opinion. But when it came to the doctor, the second one is the doctor, their family doctor. Even there, they said 30% only said they'll believe what the doctor said. So they'll probably take somebody else's opinion as well. So the word of mouth is very, very important. So when here, it's the family and friends or the people who had come to a hospital, have experienced the services, and they are the people going back and saying that. So 70% of the patients come based on the previous patient's experience. So leveraging that word of mouth becomes very, very important. How do we leverage that? The word of mouth can be done only through quality. The quality, when we talk about, there are two broad aspects. One is a clinical quality. When we say clinical quality, it's about the medical care, what the doctor provides. The second is the nursing care, because ophthalmology is a teamwork. Doctor alone is not there. You have at least, even any practitioner who's got a reasonable surgical volume, will have about 8 to 10 people supporting him in various activities. Third is the outcome, what you have done and what is the results you are able to give. The second part, which is equally important, is the service quality, which is about pricing, the ambience and the facilities and the transparency. So this is the patient knows about the service quality part. They know the prices across the system. They know which place looks better, what are the facilities available in different places. So you have to keep it updated. Whereas the clinical quality patients do not know much, but you have the responsibility to provide the best for them. So I'll just give you an example you are able to see. So this is the cataract surgeries in India, which happened between 1985 to 2011. So can anyone say why it started increasing from the year 92, 93 onwards? The volume as after that, up to, I can even say, even if you go 10 years beyond 1985, even up to 1975, the volume were 1.3 million. Last year, India did about close to 8.5 million cataract surgeries. But when you talked about 82, 83, it was only 1.2 millions. So the intraocular lens surgery. So when the intraocular lens surgery, why did the volume go up? Okay, results were better. Then what made the results get more patients? Active? Early detection of cataract. So the patients have to come seeking treatment, isn't it? So it's not just only the patient, the doctors also changed. Okay, in the sense, till 91, 92, when we were doing only intracapsular cataract extraction with a pair of glasses, we were only selecting patients who were blind, patients who had a 1 meter vision, 2 meter vision, or FCF. That's what we operate. Because even after surgery, the patient is going to see only 1/60 without an IOL inside. So they need to wear a glass to see the distance. So when you put an IOL and you are able to give the patient able to see 2 or 3 lines without the glasses, then your threshold for advising surgery suddenly went from almost perception of light 1 meter to 6/36, 6/24. So so what I'm telling is the quality. So when you are able to provide a better quality, not only the patients change, you also change. You also have a belief that I can do that patient, give them a much better vision. Earlier we thought, even if somebody is 660, will never operate. So those are the days we used to prescribe homatropine eye drops or phenylephrine eye drops so that people can dilate and they can see better. There are many patients, your drivers who got a posterior subcapsular cataract with 6/9 vision, we give them homatropine, allow them to drive. So now that IOL made a huge change, not just for the patient, but also the doctors. And again, what also made the volume go up is the support from the government. When you talk about 99, 2000, government also said, anybody who's doing a cataract surgery free, we will pay you certain amount of money. So that again, making it the quality, making it affordable is very important. That is not just for the country, but also for our thing. But we recently did a study looking at what is the pre-operative mean logMAR, visual acuity in the operated eyes. And we looked at 3 different categories. One is the patients from outreach. The second one is from subsidized, direct walk-in, free patient. Third is a paying patient. So why are we talking about this? Because we said, when we are going to do IOL surgery, we are going to increase the threshold of people with poor vision to come to the hospital. They'll come much earlier. That is our assumption. That is what we are testing here. So if you take the patient from outreach eye camps who come, this is the data from 2012 to 2023. The patients had, in the year 2012, the mean, the visual acuity was only 2/60. And the 2023, it has come down to 4, it has improved to 4/60. So that is all the progress we have made. That's a mean. And if you see the direct walk-in free patients, they are better. So even in 2012, they had a much better vision than people coming from the eye camp. Okay, and if you see, it took a huge hit during the period of COVID in 2020. Again, it went back. Only people with a very advanced loss of vision only came to the hospital. Now we have come back to the 2018 level last year. And the paying patient also, in 2012, it was like 5/60 or 6/60. In 2023, that also has come down to 23. So it may be, still there may be some quality issue for the patients to accept. Patients only when their vision is as poor as 6/60, they come. So this is a data that was taken from the RAB survey, which was done nationally. Recently, it was between 2017-18, this was done. When we say cataract surgical coverage at visual acuity of 3/60, the way it is calculated is the denominator or the patients who are in the community with cataract, and the vision is the better eye. The vision in the better eye is less than 3/60. Okay, the denominator is the patients in the whatever in the numerator. The numerator were the patients who had 3/60 or less with the cataract. The denominator is these patients plus all patients who have been operated for cataract in the community. If you see that, 92% of the patient is coverage is there. And if you take 6/60, it is 87%. When you look at less than 6/18, 6/24 or something, for all the patients who have got a cataract plus you operated, the coverage is only 64%. The 1/3 of them remains. And when you go to 6/12, is what is being now recommended by the World Health Organization. Anybody vision is less than 6/12, it is advisable to operate them. That is a guideline. When you go there, only 50% have been operated. So you understand the volume of work that needs to be done outside, but you want to operate on a patient with 6/12, you have to be really good. So understanding here, the understanding of the quality becomes very important. From being subjective, instead of saying, I do a good quality, you have to monitor the outcome for improvement. So you have to also analyze from that outcomes, and you have to adopt evidence-based practices, and you have to renew that. And I'll just introduce this quality pyramid for all of you. So when you talk about quality, quality has got 6 elements. The base of the pyramid is safety. On that only you have to have patient-centered practices or policies. Only on that you'll be able to build the efficiency, the effectiveness, and it also be a timely care and equity. The effectiveness, when we say it is about the visual outcome, it is about the complication. Efficiency is how much you are able to do with the given resources. So here we are going to talk about the first 3. Safety, patient-centeredness, and effectiveness is what we'll be covering in this particular instruction course. Dr. Haripriya will talk about the safety part. She will talk about how do we deliver safe cataract surgery. Dr. Shivakumar will talk about the effectiveness part, ensuring good visual outcomes. Dr. Venkatesh will talk about the patient-centered part, understanding patient expectation and monitoring the